All right, let's dive into a skill that every single clinician needs to master, the oral cavity and throat exam. Now, I know it sounds basic, but trust me, doing it right, I mean really right, can literally save a life. And to show you how, we're going to walk through a real-world case, step by step.
So, let's meet our patient. He's a 68-year-old man, and he's come in because of an ulcer on his tongue. Now, you're going to get a lot of information, but here's the one detail that should make your ears perk up. It's been there for 8 months, and it just won't heal. That right there, that's a huge red flag, and it tells us we need to be incredibly careful with this examination.
You know, before we even think about picking up an instrument or putting on a headlamp, the exam is already started. It starts with a conversation. The patient's story is where you'll find your first, and often, your most important clues.
Okay, so let's lay out what we know. He's 68, he's got this non-healing ulcer that's been bothering him for 8 months. And then here's the kicker. He's a chronic smoker and a betel nut chewer. When you hear that combination of factors, alarm bells should be ringing. Oral cancer has to jump right to the top of your list of possibilities.
So we have the basics, but now we have to dig deeper. This is where we put on our detective hats. Asking the right questions is an art form, and each one is designed to peel back another layer of this mystery.
First up, the timeline. So why do we care if it was sudden or gradual? Well, think about it. Something that pops up overnight might be from, biting your tongue, or maybe some kind of infection. But a lesion that creeps up slowly over time, that points to something much more chronic and, frankly, much more worrisome.
Next, what's it doing? Is it just sitting there, or is it actively changing? A growing lesion is a major warning sign, because it tells you this thing is biologically active. It's not static. And in our case, the patient tells us, yeah, it's actually gotten bigger over the last 2 months. Okay, now we need to know how this is affecting his life. Does it hurt to eat or swallow? There's a fancy word for that, odinophagia. Does it hurt just to talk? These aren't just comfort questions. Pain with function like this suggests the lesion isn't just a surface problem. It's probably invading deeper into the muscle of the tongue, and that is a critical piece of the puzzle.
So just to pull it all together, you've got to hit these key areas every time. You confirm their habits, smoking, drinking, betel nut. You ask about chewing, any numbness, tingling, or voice changes. And then the big one, have you noticed any lumps in your neck? That could mean it's already spread. And of course, you always ask about family history.
Right. We've got a really solid history. Now, and only now, are we ready to move on to the physical exam. But look, you can't just jump in. A great exam is built on a foundation of great preparation. It's not just a preliminary step, it's part of the whole procedure. And this protocol here, it's not just about being nice, it's fundamental to good medicine. Introduce yourself, tell them what you're about to do, get their consent. Don't just assume it's okay, get them sitting correctly right in front of you, and please, before you touch them, just ask, are you in any pain right now? It's simple, but it's so important.
I really cannot say this enough. Good lighting is everything. You need a headlamp. It gives you this perfect, direct, shadow-free light that lets you see into every nook and cranny. It's not a nice to have, it's not a luxury, it is an absolute 100% necessity for a proper exam.
Okay, lights on, let's start the actual inspection. And listen, this is where having a system, a routine, is your absolute best friend. If you follow the same path every single time, you are so much less likely to miss something important, especially in those little hidden spots.
We start from the outside and we work our way in. It just makes sense. First, look at the lips. How wide can they open their mouth? Then, you grab a tongue depressor, gently pull the cheek aside, and get a good look at the gums and that inner lining of the cheek. Oh, and try to spot the parotid duct opening. It's right there, opposite the upper second molar. Now for the main event, the tongue itself. This is a super high-risk area. Ask the patient, stick your tongue straight out. See if it pulls to one side. Then you need to inspect every single surface, the top, the bottom, and especially the sides. Then have them touch the roof of their mouth with their tongue so you can get a crystal clear view of the floor of the mouth.
All right, our last stop on the visual tour is way in the back, the oropharynx. Gently press down on the tongue. Pro tip, stay on the front half to avoid making them gag. Now you can get a good look at the tonsils, the walls of the throat, the uvula hanging down, and the soft palate. You're looking for anything that looks off, swelling, redness, or asymmetry.
So we've looked everywhere. Our visual inspection is done. But the exam? Oh, it is not over. Not by a long shot, because some of the most critical information doesn't come from what you see. It comes from what you feel. It's time to palpate.
This is truly where your sense of touch becomes a diagnostic instrument. That ulcer might look pretty shallow, but when you feel it, you might find that it's hard and firm and stuck to the tissues underneath. We call that induration, and that's a classic sign that the lesion is infiltrating deep, something your eyes would completely miss.
The technique itself is pretty straightforward. You take a gloved hand, use your index finger, and gently but firmly feel the lesion, the floor of the mouth, the base of the tongue. Then you move to the neck. And let me be clear, a systematic palpation of the neck for lymph nodes is absolutely non-negotiable in an exam like this. So where are you feeling? You've got to know your zones. You methodically check the submandibular nodes, right under the jawline. Then you trace the entire jugular chain, which runs right along that big muscle in the neck. And finally, you check the supraclavicular nodes, just above the collarbone. You're feeling for size, sure, but also for consistency. Are they hard like a rock? And are they stuck in place? Every little detail is another clue. So let's recap. We've taken a deep history, we've done a systematic inspection, we've completed a thorough palpation. And what do we have? We have a non-healing, hard ulcer in a high-risk patient, and we can feel suspicious lymph nodes in his neck. The clinical picture is coming into sharp focus. So the question I have for you is, what do you do now? What is the single most important next step to confirm what we're all thinking? This is where the real work begins.